coming to us to talk about an extraordinarily important topic. Very contemporary, very much looking forward to this, and y'all should too. So welcome Dr. Quinn to talk about concussion.
Thank you for having me. I'm always glad to come back to lecture to you guys. I hope you don't mind, this is kind of my new lecture spot that I use in these lecture halls. So, and that way I can get the people in the back too.
What?
Can you guys tell me, can you hear me now? So today we're going to talk about concussion, and as Sally said, it's a very apropos topic. It's very much in the news, especially because of all the injuries in football and the long-term sequelae of it. And so I hope you enjoy this lecture as much as I do. So the learning objectives, what I'm going to talk about a lot is both the pathophysiology of concussions, what is a concussion, the definition, the pathophysiology, what causes concussion, and most importantly for us, we're going to talk about making the diagnosis as well as the treatment and management of concussions. So some of you may know, and some of you may not know, that I am one of my biggest hobbies in the sport that I enjoy watching the most is professional cycling. I'm probably one of the only people who really follows professional cycling, but I'm going to use that as a theme that runs throughout this lecture. So this is a picture of Tom Boonen. Tom Boonen is a famous cyclist from Belgium. He's now getting towards the end of his career. He's probably going to retire next year. He's in his late 30s. But in 2010, he was in the Tour de France, which some of you may know is a big 3-week stage race that goes throughout all of France. So for 3 weeks straight, they ride over 120 miles a day. And at one point, he had a crash. Crashing is just unfortunately part of cycling. And afterwards, he gave an interview on his experiences after this crash. And I think this interview shows a lot about the signs and symptoms of concussion. And it also raises a lot of questions about the management. Like, did they really do the right thing by him? And did he learn his lessons? So after the crash, he said, "I've got a huge headache. I was a danger to other riders too. I think I suffered a concussion. The noise, colors, I couldn't stand them. A honking car pass was echoing 1,000 times in my head. Yesterday was a dark day, due to the rain, and maybe that's why it went better. Friday, I vomited." The Belgian rider had a rough night during which he couldn't sleep. On Friday morning, he threw up, yet still started the stage. In hindsight, starting the stage didn't seem like such a good idea, but that's cycling, said Boonen. If you can put on your racing number, you can race. So just keep in the back of your head some of the signs and symptoms that he talked about, and whether or not he probably should have gone back to riding. So we talk a lot about concussion in sports. It's obviously not the only reason people get concussions. Motor vehicle accidents are a really common cause, falls. But unfortunately, most of the data and management comes from sports. But there's very little evidence-based medicine. Most of the management comes from consensus. And if you want to have a good time, try to get yourself on one of these panels, because most of the concussion management comes from either, there used to be the Prague Convention, the Vienna Convention. The latest one is in Zurich, which was in 2012, and where I'm going in 3 days. So again, it's a group of people who get together and look at the minimal evidence and decide this is probably how we should handle concussions. So when I keep throwing this word around concussion, what do you guys think, what is a concussion? Okay, so it is, it's a hard to say, traumatic brain injury. It's definitely on the mild, of the spectrum of traumatic brain injury. It's on the mild aspect.
Diffuse? Diffuse?
It's diffuse, definitely. Is it loss of consciousness?
Maybe.
No. Not necessarily, right? You can have loss of consciousness, but not always. And that's what makes it really difficult. Yes?
I think our neurology counterparts define it as symptomatic, the dizziness.
It is, and that's part of the signs and symptoms. There's definitely 4 categories of signs and symptoms, both and we'll talk about this extensively. There's somatic and there's physical. So the dizziness, it's more of an axonal injury or an impulse, and it's more of a metabolic problem, actually. So it's not a structural problem, and most people who have a concussion actually have grossly normal imaging. So, and not all of them have loss of consciousness. If everybody who had a concussion had loss of consciousness, it would be easy, right? But they don't, and it's also very fleeting. And so a lot of times they won't have symptoms by the time the patients come to you. So the actual definition of concussion, it's a complex pathophysiologic process affecting the brain induced by traumatic biomechanical forces. So it's an impulse type of injury, and it's and it affects the brain. And really, there's four main parts to it. It's an impulsive force to the head. Doesn't necessarily mean that you get hit in the head. You can get hit in the neck, into the shoulders, but as long as the force is transmitted to the head and causes an impulse to the head, it will cause a concussion. It's very rapid onset and short-lived neurological dysfunction. So again, you kind of get what they used to call a stinger. You get hit and all of a sudden you're just a little bit dizzy, and then the symptoms are gone, and a lot of the players will just wave the coach off, hey, I'm fine. Again, it's a functional disturbance rather than structural. And the problem is making the diagnosis is there's no markers for it. There's no way you can get a troponin for a concussion. It's a graded set of clinical syndromes. And you put all the little pieces together, and that's how you diagnose somebody with a concussion. And as I mentioned before, you have grossly normal imaging studies if you choose to image the patient. And we're going to talk about which patients need imaging. And again, remember, 10% of all concussions have no loss of consciousness. So this is really important if we have somebody who comes in from a motor vehicle accident, for example. You may have somebody who had a concussion during their MBA, but they never had loss of consciousness. So talk a little bit about signs and symptoms. This is a race last year in Holland. There was these huge crosswinds, and they got knocked into a ditch. So the signs and symptoms, basically they come from four main categories. You have the cognitive, the physical, the emotional, and sleep. And when we went through Tom Thornton's description, he pretty much hit all of those. He was talking about how he had difficulty concentrating, and people are kind of just slow. You ask them some orientation questions, and the simple, how many fingers am I holding up, or where are you right now? They've been shown not to be very reliable because, especially athletes who make their living on their sport, they know the answers to these questions, and they lie. So there's a specific set of questions that you end up asking the athlete. So the physical, right? He said he had a terrible headache, and then he started vomiting. Granted, his was 3 days out, but you can have nausea and vomiting, the dizziness, and he was talking about how the car horns of the caravan in the peloton were really, really loud, and so you get phonophobia, you get photophobia. You also get balance instability as well. And you get very, very nervous and anxious and jittery. And that's why he was saying that he was a danger to the other riders, because if you're in a peloton of 100 cyclists, you need to have confidence in handling that bike. And so if you're nervous and at all, then you're a danger to yourself and to other riders. And then the last component is sleep. People who have concussions have a really tough time sleeping. They have a lot of wakefulness, and they can't get a good night's sleep. So talking a little bit about the pathophysiology. Just as an aside, I was practicing my lecture last night at home, and my 3-year-old son couldn't fall asleep, so he was sitting next to me on the couch, and he saw this picture, he goes, "That's not good." He's like, "What's that on his face?" I'm like, "It's a big Band-Aid." He's like, "Yeah, he needs a big Band-Aid." So when I give these type of lectures to my med students, when they see a slide like this, they immediately start writing it all down and trying to memorize everything. I don't think I have that problem with this audience, but my point is, please don't memorize the slide. It's more just really to get the concept. Again, concussions are not a structural problem. They are a metabolic problem. And what happens in a concussion is you have a blow to the head or an impulse to the head, which causes rapid depolarization of multiple neurons in the brain. And as they depolarize, they release neurotransmitters such as glutamate, and that causes an efflux of the calcium out of the neuron, which is all well and good, but the problem is to maintain neutrality, you've got a lot of calcium going back into the neuron. And as you're depolarizing all these nerve cells, they require more and more energy to continue to fire. But the problem with is the calcium, it actually hinders oxygen metabolism. And so the neurons can't produce ATP that they require for that increased energy demand. And this is going on over and over again, and so that's why the neurons aren't working to their efficiency, and that's the mechanism for the anxiousness, the confusion, the amnesia, because they're not getting the energy that they need. And also, the calcium can cause actual swelling to the neuron itself. But again, it's not really a structural problem, it's more of a metabolic problem that they're not producing enough ATP. So a little bit about the epidemiology. Again, I'm focusing a lot on sports because that's where our data is from. That's where it's in the news. But in fact, most concussions, a lot of them do come from MVAs. There's about 40,000 motor vehicle, 40% of all traumatic brain injury is from MVAs, and there's about 1.7 million TBIs every year in the United States. As someone mentioned, concussion is on the spectrum of traumatic brain injury, and it's on the mild spectrum. It's something you're going to see, 1.3 million ED visits. But notice this discrepancy here, right? There's 3.8 million concussions in sports, but only 1.3 million ED visits. There's obviously a big problem with the reporting data. Why do you think that is?
Underreported.
It's underreported, especially in football, especially in some of the other sports. I think there was an article in the New York Times maybe a month or two ago where they looked at all the concussion data from the NFL, and they were supposed to have a database of all the concussions in the NFL for a certain amount of years, and then they realized like Troy Aikman had a documented concussion during that time period as well, which was almost career-ending, and some of the other football players, they weren't in that database. So there is a huge underreporting of concussions, especially in the National Football League.
So did you see the movie?
I have not seen the movie yet, yeah.
It's like literally about this, and this one physician who is trying to basically expose the NFL and what they were doing for years, knowing that they were sending players out on the field with severe concussions and giving them things like morphine just to get them going. But it's fascinating.
Yeah, I have to definitely see it. Obviously, it's an interest of mine. But yeah, so there's a lot of cover-up, and there's an example that I'll give even later afterwards.
Dr. Quinn,
Yes.
I think the interesting thing about that movie also was sort of the long-term sequelae. Like a lot of these athletes were going on to like kill themselves.
Yeah.
There's this whole idea of the chronic traumatic encephalopathy, where these young, like Junior Seau, young
Exactly.
guy who then kills himself, and it's like sort of what's happening. And so it's really interesting. I think the NFL actually they've given a certain amount of millions of dollars actually to NIH to actually study this phenomenon.
Right. The NFL has it also. I think boxing is a big sport where they're trying to do some concussion research as well. So this data is a little bit old at this point, but this is a pie chart of all the incidents of concussions. Generally, every year the incidence of concussion goes up about 7%, and that is because there is more education in terms of diagnosis, and especially in sports now, in high schools and middle schools, coaches are really, it's a big push to pull a kid when they have a concussion, especially now because of this long-term sequelae, and so that the athlete is not going to go back to play. Again, the most common reported sport in the United States that causes concussion is football, but it also has the most number of participants, so that's why it has such a high incidence. But what's really interesting, this number here for ice hockey is 8%, but that's actually the average of men's and women's ice hockey. But but women's ice hockey actually has an incidence of about 18% of all concussions come from women's hockey, while 8% come from men's hockey. So that's where the average comes from. So are women hockey players just more aggressive?
No, they're worse skaters.
There's more skating.
No, they're worse skaters.
They're worse skaters. Okay. Coming from the, yeah. But it's probably a real problem with reporting bias, right? More men hockey players are professionals, and so then again, once you get into that realm of professional hockey playing, it's your livelihood, there's probably a lot less reporting. And that's why you get this huge reporting bias when it comes to men's hockey. So this is what's important for you guys. So now that talked about the physiology and the epidemiology, what you guys want to know is how do we take care of, if the cyclist comes in and into the ED. This bike here, how much do you think?
Where's the guy on that? Where'd he go?
Yeah, I think that's him, which is also why, as you can see, landing on your shoulder, that you always want to check the clavicles. So how much do you think that bike is worth that's lying there in the water? At least 10, yeah, probably $12,000 in the water. That's a lot of money right there. So I'm going to try to see if I can pull up this video. This was just, again, an example of this is Chris Warner in the 2011 Tour de France after he had a crash. Wait, is the volume working?
I think it was muted on the actual.
I know how the noise works. Who muted it? Who muted it?
You can leave the.
How long? I don't understand. How long ago was it?
It was about 25K from the finish.
We've been chasing for 25K?
Yep, yep.
Oh man.
Johan, bad luck.
So he crashed. He rode his bike to the end of the race, and he has no idea what happened. Okay, he's like, we've been chasing for 25K. So, and that's a classic description of a concussion. Like, he's amnestic to the event. He's with it now, but he has no idea what was going on. So again, in terms of making the diagnosis, because all our guidelines are from the Zurich Convention, and the diagnosis is a very clinical diagnosis. Like I mentioned before, if you have loss of consciousness, it would be easy. But a lot of times these patients will come in, it's a fleeting phenomena, and you don't know if they have it. And we want to pull these patients from the field. They should not go back to play, and we'll talk about why that is. So oftentimes, there's not going to be a physician or a neurologist on the sidelines. Right? Even though the NFL requires an RSI-trained physician to be at all NFL football games, so hopefully it's physicians who are making the decision to pull a player, but again, there's a lot of money involved, unfortunately, and some unscrupulous people. But often, there's going to be just coaches. You're at a youth soccer game, it's moms and dads having to make a decision whether or not to pull a kid and if they had a concussion. So, as with any type of head injury, there's certain steps that everybody should follow. You assess for cervical spine injury. And then we have something called the SCAT-3, which is kind of a clinical decision, not a clinical decision, but it's an assessment tool for concussions. There's a whole bunch of them. This is the one that's the most well-known, none of which have been really validated. They're not made for physicians, they're actually made for lay people to decide whether or not to remove somebody from play. And it's really, really, really important that the patient may not be allowed to return to play, because the diagnosis has to be made by a physician or even a neurologist. And there can be a lot of very serious life-threatening sequelae if they go back to playing. And you should observe the patient for several hours after injury. So what is the SCAT-3? The SCAT-3 stands for Sports Concussion Assessment Tool. It's done on the sideline, either by the coaches or maybe trainers, but it's not meant to be, doesn't have to be a physician who uses this. And it's based on 3 portions. There's the GCS, obviously, to determine how severe the injury is. Most of these people with concussions will have a GCS of 15 or 14, but again, it's the mild spectrum of TBI. And then they have something called the MADOC score, and that's kind of the orientation type of questions. Again, asking where are you, how many fingers am I holding up, to you're fine, go back, just has not been shown to help. And so here up close is the MADOC score, and it's very specific to the venue, again, so that people can try not to fake it. There's a question like, where are you today, what sport are we playing, what half is it now, who scored last in this match, and that's to check for anterograde amnesia. So amnesia 30 minutes before the event and up to the event is very suspicious of having a concussion. What team did you play last week in the game? And it's kind of to determine how far back this amnesia goes, and did your team win the last game? They also have a child SCAT-3 out now for